What's good, fam? It's your host, Jim Pruitt, aka PharmD in the ED, and we're listening to another episode of the Pharm So Hard podcast. Today, I have a very special episode, and this is going to be for all of our docs out there in the ED treating patients with pain. Today, we're going to talk about ultrasound-guided nerve blocks. And of course, I'm not going to be talking about this because I have no clue. But I have two guests on, and we're going to have a few guests going to join in virtually as well to talk about this. So before we get started, go ahead and introduce yourself to the audience.
Hey guys, happy to be here. And I don't know if I believe Jimmy when he says, yeah, I got no idea what's going on here. He's been a great resource to have. But I'm Oliva Shah, one of the ultrasound trained faculty here at MUSC, and I also help guide the fellowship in emergency ultrasound.
And my name is Cummings. I'm the ultrasound fellow and Dr. Shah's minion here at MUSC. Thanks so much for having us, Jimmy.
Perfect. So I wanted to get into why this topic is important, because I think it's one of the cool things. We've had our run with ketamine, we've had our run with using things like droperidol, and that's all drug related. But I think ultrasound guided nerve blocks are going to be pretty cool because it's going to be a developing area for EM physicians, because especially those that are ultrasound trained, and pharmacists need to be aware of the pharmacologic needs of the ED and making sure we stock these things accordingly. Can you guys talk about the importance of ultrasound guided nerve blocks?
Yeah, absolutely. So I think you're absolutely right. I think over the course of time, we've kind of expanded our purview of what medications we use and for what different purposes. And really coming down to it, the most important thing is tailoring it to the patient, trying to use a multimodal approach to meet the needs of the particular patient in front of you, instead of just hitting everyone with a opiate via IV pain medication administration. It's much better to kind of look at this person in front of you with a fracture, and can we isolate the area where this patient has pain and try to minimize the systemic effects. And that's where I think that the area of ultrasound guided regional anesthesia has so much promise.
I think for me, and this may sound selfish, but it's really fun to do. It's really enjoyable for me, so it keeps my satisfaction in the job up. But really, it's all about the patient and the patient that's in front of you and the procedure that needs to be done. And oftentimes, this is the most elegant and most efficient way of accomplishing what you need to do.
Perfect, guys. So for those that are not very familiar with the technique and just the overall history of ultrasound guided nerve blocks, can you just give us an overview of what is it and where the data come from? You don't have to go deep into the data, but just give us a general overview of what this particular thing is.
Totally. Yeah. So since I've been in training, which is relatively recent, we've been doing a lot of these blocks, regional anesthesia, I should say, ultrasound guided. But going back further than that, we've been doing this for a long time, really. So initially, we were doing a lot of landmark guided procedures, and we still do in certain cases, but that has sort of transitioned over the course of time. And there was a period where we kind of got away from doing these techniques because they were maybe not super reliable, maybe you weren't getting a dense anesthesia from it, and a lot of that might be, we think now, related to the technique of doing it landmark guided. So people kind of gotten away from that a bit, and then we see our anesthesia colleagues incorporating the ultrasound with this for people who are going to the operating room, for example, and that has sort of made its way back to the ER more recently.
Perfect. So one of the things that come up quite often in my interactions with other providers is the training that's associated with it. And I'm noticing that some providers that are recently graduated from fellowships, particularly ultrasound, are very keen to doing these procedures. And I want to see, what is the training, whether there any credentialing process and certifications to effectively perform ultrasound guided nerve blocks?
So in terms of training, it really is going to be dependent on what you have access to. So for me, having trained residency relatively recently, I was exposed to this kind of early on during that stage. For a lot of folks out there, this is not going to be something that you're familiar with. Maybe the ultrasound is in and of itself kind of a foreign thing that maybe you just use for central access because that's kind of become more of a standard of care. But really the techniques are very similar. It's really just needle guidance with the ultrasound machine. So in terms of the training, you just want to make sure you have a safe introduction to some of these techniques because it does require a certain skill and dexterity. As far as the credentialing and certification is concerned, there's not a clear certification to do this. It's generally included in the certification to do any kind of regional anesthesia. So you can use ultrasound guidance as an adjunct to anything that you would have done landmark guided previously, which kind of falls under the general scope of privileges of EM. But there is going to be some specific credentialing depending on what institution you work at. So you want to make sure that before you go around doing this on patients that is evaluated and that you know what is in your purview for the institution that you work at.
Perfect. One of the things that I actually, you kind of mentioned it before, but your residency or fellowship is going to be the people who's probably providing this training, or if there may be some type of really cool conference you can go to that can teach this as well. Is there any continued education required, whether you're ultrasound trained or whether institutions, have you heard about this from different institutions, whether there's a certain amount of continued education that's required for not just nerve blocks, but for ultrasound and different skill sets that's needed to perform this appropriately?
Yeah, Jimmy, I think definitely you have to have continuing education. You have to be purposeful in your self-training, not only in learning different blocks for different situations, but learning different agents to use and reviewing the safety. I personally just listen to a bunch of different medical education podcasts, and whenever I hear about a new block, like I remember learning about the PANG block for an acetabular fracture, and I just used it on the next shift and it worked great. Because again, like Dr. Shah mentioned, it's the same technique as any of the other ones, and then sort of just looking at a video of the block, identifying the patient's anatomy and proceeding with the procedure oftentimes is enough, but it's something that needs to be done frequently and repetitively in the future.
Yeah, just to add to that, I think definitely anything ultrasound related or procedural related, you want to make sure that you're having continued experience. Like, for example, even for diagnostic ultrasound, to maintain your credentialing privileges, at most places you're going to need to do a certain number of exams per year or per whatever the period is that you're evaluated. And I think the same is true for ultrasound guided procedures and regional anesthesia. So you want to make sure you're doing this frequently enough that you're staying facile with it. And also, as you're going about incorporating this into your practice, you're going to start with some of the things that are simpler, lower risk, and more often performed than some of the more advanced blocks that we might talk about later on.
Perfect. So I wanted to transition now into the question that most people have. And when it comes to nerve blocks, and I really want to specify the ultrasound-guided nerve blocks, what is the overview of what the data says as how safe these things are to do, and if there is, what's the efficacy compared to the standard of care without using these ultrasound-guided nerve blocks?
So first things first, safety, because that's the most important thing. So I think the data shows in general that these blocks are safe to perform. There is mostly a theoretic risk that's associated with it, and this is derived largely from a combination of ED and anesthesia literature, so it's a little bit heterogeneous, but you have to take that with a grain of salt. So largely the biggest risk factors are going to be kind of local injury to the area where you're putting a needle, and then there's going to be the systemic effects from the anesthetic toxicity as well. So whenever you're doing this, you want to make sure that you review all the indications, contraindications, just as you would do with any other kind of procedure.
Perfect. So what I've looked at briefly is the fact that the odds of these, major safety events like LAST or having these injuries are like 3 in 10,000, 8 in 30,000. So just less than 1% of the things that happen. But I think making sure you have guidelines and protocols to make sure that you're following the correct technique seems to be something I found across most of the studies. And usually when using ultrasound guided, I've been able to see a decrease in all minor and major adverse effects when placing these nerve blocks as well.
Yeah, Jimmy, and I think the most important thing is it's just like with all other procedures in emergency medicine, is to hope for the best but prepare for the worst. So even in the simplest of blocks, I'll always have the patient on pulse oximetry, on the cardiac monitor, knowing where the intralipid is, and obviously probably just as importantly, I've talked to my ED pharmacist beforehand and planned out a strategy for what to do and what to do if things go wrong.
Yeah, absolutely. You want to make sure you have an action plan in place to be able to deal with adverse events quickly. I mean, it's extremely unlikely, just like you said, it's really case reportable, essentially in the literature, to have these events happen. But to try and avoid it, we do things like try to avoid intravascular injection and things like that, where if you don't have the appropriate technique or the appropriate understanding of how to perform the procedure, certainly you could have a higher incidence of these adverse effects. So you want to make sure that you're comfortable looking out for these things.
So I think the key thing is just to summarize what we talked about so far is to get the training that you need within residency and fellowship training. And if you don't have that, there's maybe workshops you can go to obtain this training, but it doesn't just end there. You have to have your continued education to make sure you perfect this craft along with other things that you're very comfortable doing, but just making sure you're doing that. And as far as safety, it seems to be a very safe procedure to do. Granted, you have the right protocols in place. So pharmacists, that's listening, one thing that you can do, and your admin would love you for, have these lipids in the AccuDose, the Omnicell, whatever your automated dispense cabinet is going to be, have that there. Also, create your power plan, get your residents involved, and help them understand the process of making something like this a rare procedure that can occur, a rare adverse effect that can occur. Make sure you have a game plan across the board, and making sure there's kind of a timeout for these type of procedures, and saying, hey, this is what we're going to do, this is our backup plan, and where are these things located. Also, pharmacists, actually go to your Omnicell, go to your AccuDose, look inside and make sure you have it. Make sure you have the filter needles that you need. Make sure that your pump is set up to administer lipids in the manner that we need it to go. So I will get more into that in a later episode, just talking about labs in general, but just for the sake of this one, pharmacists, talk with your physician staff, meet with your administration, and make sure a protocol and the meds are needed, that are needed are there for you to use. Okay. All right, guys, so we talked generally about all of this. So can you walk me through the most common nerve blocks that you're doing in the ED, and really go down what you're using and why you're using those local anesthetic agents?
So probably the most common blocks that I find myself using are going to be for procedures, for sure. So hand lacerations, foot lacerations. We're doing a lot of hand blocks with, and that's all three nerves, so median, radial, and ulnar ultrasound-guided blocks, as well as posterior tibial. We're over here in a beach town where we see a lot of patients that run barefoot around the beaches, and will get seashells and oyster shells and whatnot lodged in their sole, and obviously directly injecting local anesthetic would be pretty painful, and being able to go away from those sites where there's going to be a lot of hesitation and anxiety from the patient that itself needs to be treated, whereas you can do a little topical anesthetic, inject a little bit of local, and then do an ultrasound guided block, and it's relatively painless for the patient. It's elegant, and the patient satisfaction is outstanding. So those are probably the most common ones that we do. I've historically had a lot of patients that are morbidly obese, really old, that just would not be best suited with a traditional approach to, say, for example, reduction of a shoulder that fails non-invasive maneuvers like the Cunningham technique or other, non-invasive techniques that will ultimately need to be sedated. But it's more elegant and safer for the patient and quicker, rather than getting a whole sedation setup, to do an ultrasound-guided interscaling block or do an ultrasound-guided intra-articular injection. And being able to do that really is oftentimes what's best for the patient and what's best for the department.
Yeah, I agree with that 100%. I think that, a lot of times practitioners will get a little bit wound up about seeing what other institutions are doing with regards to ultrasound guided regional anesthesia, and they're like, oh man, that looks pretty advanced, kind of complicated. But it really doesn't have to be. A lot of people are doing landmark guided wrist blocks, and the efficacy data shows that when this is performed landmark guided, it's efficacious maybe 60 to 80% of the time compared to ultrasound guided. Seems to have a lot higher percentage of patients that get adequate analgesia. So you're going to be more successful if you do this ultrasound guided, something that you might be doing already. The other benefit of doing some of these, what I would call like kind of simpler or gateway kind of blocks, is there's not as many obstructions to performing. So there's not going to be like vasculature in the way. There's not going to be like in the realm of thoracic blocks like pleura in the way that is going to make you a little bit nervous if you're not as comfortable with doing ultrasound guided anesthesia. So it's a lot more accessible to people who maybe have less experience. And finally, the most important thing for me is I love doing these blocks because you get to see the end result, right? So you can be going through and, you know, fixing someone's partial finger amputation or fixing a bunch of lacerations on the sole of the foot, which is a really historically painful area for patients to get procedures, and the patient's just sitting there chatting with you and they're in zero pain. So you get to see the effects of that block immediately, and patients do great with it, compared to something like a femoral block or, you know, rib blocks, things like that, where the patient's not necessarily going to sit in the emergency department for the duration of that block. So a lot of times patients go upstairs and you don't get to directly see the benefit. So it's a lot nicer to have that in front of you when you're starting to do that and get that kind of reassurance that this is actually helping the patient.
Perfect, guys. So if we can really just go, I like to do things head to toe because it helps me identify things. And just talk about some of the blocks you're doing, but more importantly, what agents you're using. Because sometimes you want to use lidocaine for a quick on, quick off deal. Sometimes you want to use ropivacaine for something to last a little longer. And some providers, depending on your background, can use bupivacaine for even longer blocks. So can you just go through the most common ones you've actually done and what agents you use and what's your rationale behind it?
So starting from head to toe, probably the head and neck one that I'm using the most is the superficial cervical plexus block. And I'm oftentimes just using 1% or 2% lidocaine, plus or minus epinephrine. It really doesn't matter to me in this instance because it's really just almost the same as intradermal. It's just local anesthetic. It's really simple to do. Identifying the anatomy is a breeze, and if I'm doing it for like an internal jugular, central vein catheter placement, then it's really nice because oftentimes we change where we insert the needle there, and then how we secure it, and the patient, comfort is really important during that too because it can be a long procedure. But yeah, I usually am just using lidocaine for that. Moving down, probably for shoulder and proximal humerus, we're going interscalene and supraclavicular brachial plexus. A little bit more complicated anatomy, but I've only watched a handful of videos and had a few lectures, and I've had it's pretty easy to do. Again, same technique as doing sort of our other blocks that we're more used to. Don't have a lot of experience yet with doing the chest wall blocks, mostly just because I haven't had any patients, during my fellowship that have had massive chest wall abscesses or massive axillary abscesses that weren't going to go to the operating room, but could be useful in a more of a rural setting where, I'm looking at transferring a patient, and this is just going to be easiest for me and for the patient to do those.
Yeah, kind of moving down. So, I think the one that comes up a lot is interscalene as well for these proximal humerus fractures or for shoulder dislocations. That's, a great example of how you need to tailor your anesthetic choice to the particular indications, contraindications, and the nerves that you're going to hit. So one specific thing that comes up with that is the chance of phrenic nerve paralysis is really high because the phrenic nerve runs in that area. So just to kind of further exemplify that, each block is going to have its own pitfalls. So there you want to use something that's super short acting, and really patient selection is key, right? So you're not going to be using this on your COPDers or people who already have some respiratory compromise, where unilateral phrenic nerve paralysis, where it's going to knock out one of the diaphragms, is going to cause you problems with the patient able to appropriately blow off the CO2 and oxygenate. So that I'm going to use something short acting. So some places have like 5-chloroprocaine, which is like super short acting. Most of the time I'm just using plain lidocaine, no epi, and you're going to get about an hour's worth of use there, and most of the time that's fine because you're doing a reduction, which is a relatively quick procedure. It would be great for the patient to have a little bit longer acting analgesia following the procedure, but really the maximum pain the patient's going to experience is during the procedure. So as long as you can kind of target that period of time, that's fine. Compare that to sort of a femoral nerve block where the patient has a fracture. It's probably the most common indication is a proximal femoral fracture. We want that patient to have analgesia for a long period of time because it may be a day and a half before the patient's able to go to the operating room, and you want them to be able to tolerate that pain overnight a lot of the time without having to consume a lot of opiate analgesia. So you're going to choose something a lot longer acting. In our case, we use ropivacaine. So that's going to give the patient about 6 to 8 hours, maybe a little bit more.
Perfect. Is there any other blocks from like a toe reduction or anything from the lower that you would be using? Again, this is usually for the most common, but is there anything from a lower other than the femoral? Because I've heard these are 3-in-1 blocks, a few other ones that are in that region, and what agent will you use for those?
So I have done a bunch of lower extremity stuff since I work on the pediatric emergency department side as well. So we get a lot of kids that slip and fall. So we do a ton of posterior tibial nerve blocks, and I have done a handful of adductor canal saphenous nerve blocks. And again, for the most part, I've gotten away with doing lidocaine only, but there have been times where I've had suboptimal anesthesia just because, okay, I've done the block and here comes a cardiac arrest or here comes a massive trauma and it's 90 minutes before I can actually get around to doing the procedure. So I've moved more towards using longer acting agents, and my preferred agent is ropivacaine. Lasts not quite as long as bupivacaine, but it probably has less cardiotoxicity effects, so that's just been my practice, and especially with the compartment blocks that we use. So for example, the fascia iliaca compartment block that we mentioned, I'll use ropivacaine sort of for that, as well as saline, since it's going to be a large volume.
Yeah, I think the big point here is, like, are you targeting an individual nerve like you would with what we call like a wrist block, so medial ulnar radial nerves, or even like a posterior tibial block where you're going to get the sole of the foot primarily? Or is this a more proximal nerve block, like a femoral or fascia iliaca block, for example? And a lot of those more proximal blocks are going to be what we call or refer to as like plane blocks. So you really want a large volume of anesthetic to bathe kind of all the nerve fibers that travel within a certain muscular plane. So knowing your anatomy for those plane blocks is key, and also knowing all the different nerve fibers that you're going to hit. The blocks that are a little bit simpler are when you're isolating a single nerve, because those distributions are much more well known, and you know you're going to get adequate analgesia in that particular distribution. It's funny that you bring up the pediatric side too, because in adults we don't often have to think about this as much, but in terms of the toxic levels of dosing, especially for like a medial ulnar radial nerve block, we're talking about 5 cc's of volume per nerve. So it's 15 cc's. Pretty much any local anesthetic you're going to use in the concentrations that are readily available in the ER is going to be safe for an adult. But when you get to the pediatric side, it becomes a lot more important to think about those dosages. So if you're thinking, about using something a little bit longer acting, then you want to make sure you're not going to exhaust all your local anesthetic. In the same degree, with an adult, if you need to redose them, for example, if their block wears off and you get sidetracked with something, it's okay to redose them. It's not ideal. But in the pediatric side, you may have reached your limit, and then that's going to limit your options going forward.
Perfect. So that was a good review of just the different blocks and the different agents. One of the things that come up, and I'm a pharmacist, I like to try to help get the equipment in the room, get the agent in the room. What's some of the equipment and the supplies that you need to have available for you to do this? Because what happens if you get sidetracked, you don't have the agent in front of you, and then I've seen some providers just say, forget it, just give them Oliva, give them something else because I don't have what I need. Is there any special equipment and things that you guys need to perform these nerve blocks?
So it depends on the patient. I'll say that from the pediatric side, say for example we're going from the 5 to 9-year-old range, sometimes we will need a little anxiolysis, and a little anxiolysis goes a long way, as well as some distraction for these kids. So we oftentimes will have the child life specialist come to help distract them, put on some topical anesthetic. Since it's going to be unbroken skin, we usually just use LMX, which is 4% liposomal lidocaine. So I'll use that as well as a little skin wheel. So I always try to have a little extra anesthetic set off to the side, just to prep, especially for kids. Of course, they're always going to be on pulse oximetry and telemetry, so I always have them on the cardiac monitor. Other than that, it depends on what your emergency department has in stock. Certainly for dexterity, it's easiest to use a block needle. So we have the Sonoplex 2 block needle, which is a 21 gauge, 100 millimeter echogenic needle that has little notches in it that allows you to visualize it more easily on the ultrasound. It's not always available, depending on where we're working. So, but it is easiest for guiding the needle. If I don't have that, oftentimes I'm using a dental aspirating syringe, and depending on how far away the nerve is from the skin surface, I'm either using just a long hypodermic needle or an LP needle. And so those are what I usually have, as well as if I'm doing a compartment block large volume, of course you'll have to have sterile water, sterile saline, sterile water rather, to give you some volume, as well as a big syringe with the lower lock.
Yeah, I agree with that. So I think for me, number one is if you have access, or you should create if you're thinking about doing this, a checklist. We know that that's helpful anytime that you're doing a procedure. So try and either find a checklist. I know Highland has a great one, or develop a checklist in conjunction with your team at whatever institution that you're working at, so you can go through that each time you're going to do one of these blocks, because there are several steps involved, and you want to make sure you don't miss anything. Some things that I've found helpful is having a little handy app on your phone to kind of check and double check your anesthetic doses. And always you want to make sure you look at the bottle. You know, don't just trust the syringe that someone hands you. Even though you have great pharmacists in the ED, you want to check and double check for each other. So check the bottle, check the concentration, because a lot of these anesthetics come in different concentrations. Plug that into your app, find out the patient's weight, and make sure that you're only pulling out as much anesthetic as is safe to use, and that way you're not going to go over that limit. One of the other things that I like to do is, as soon as you identify that this is a patient that might need a block or might benefit from a block, start kind of talking to the patient about it, and start gathering your supplies at that time. So that way when it comes time to do it, you have everything kind of set out in front of you, and you can just go ahead and do the block. I initially, when I first started doing these, I would actually literally pull out the intralipid and put it on the desk next to me, because it's supposed to be in the Pyxis, but like we mentioned before, you want to make sure that it actually is physically there. And then I'm a little bit superstitious at times, so it's always nice to have it right there in front of you.
Well, you gotta bring an umbrella to prevent it from raining.
Exactly. So do the steps in the order of your checklist, but most importantly, do it the same way every time.
Perfect. So I don't want to get too in depth when I ask this, but the most common block you've done, just from some of our audience has never done this. I've been in certain shops where, some providers have never done it. The pharmacists are definitely not, involved as much. Can you just describe like what you're doing, like a step-by-step of the one common block you've done, or the most recent block? Like what exactly are you doing, so people can use this and say, oh, this is first step, this is second step, this is what I'm looking for.
Sure. So let's just say, for example, that we have a median nerve block that we're going to do. So, for example, for the laceration to the palm of the hand, pretty accessible. It's a good gateway block, like you mentioned, Dr. Shah. And really, the steps aren't too different than the landmark guided approach in terms of making sure that it's a safe procedure. So, obviously, informed consent, sterilize the skin that you're going to introduce the needle in.
Yeah, copy was not. Sorry.
Oh, no problem. You want me to just start?
Yeah, just start from the top.
Sure, absolutely. Yeah. So let's say, for example, the median nerve. So if you have a patient that has a laceration to the palm of the hand, the steps really aren't going to be too much different than a landmark guided approach in terms of making sure that the procedure is done safely and that there isn't accidental injection of the anesthetic into a place that you don't want it to go, like into the center of a nerve fiber or into a vein or an artery, obviously. So usually I'll start out by sterilizing the skin, identifying the anatomy prior to even inserting the needle, identifying proximal and distal to the site that I intend on inserting the needle to make sure that there is no interesting anatomical obstruction to doing this, something that might make the procedure unsafe. So I'll always put on color Doppler to make sure that there are no overlying vessels. Also, sometimes there will be things that are hiding in there, like foreign bodies that you didn't expect to be there. So I've been surprised more than once. So I always try to identify the anatomy, proximal and distal, to where I'll be inserting the needle first. So after inserting the needle, sometimes once I identify the trajectory of my needle and my target, I'll realize that I'm not going at an appropriate angle, or that I inserted it at a depth that's not going to get my needle tip where I want it to be. And I don't have a problem withdrawing the needle, adjusting my angle, because really you just want to do this in the quickest time possible to minimize the anxiety that's associated with it, especially in the pediatric patients. After that, I'll insert my needle slowly. I usually do this in the long axis for most of my ultrasound-guided nerve blocks, just so that I can clearly see the length of the needle, and clearly see where my needle tip is. And then as I'm advancing, just prior to injection, again, withdrawing, aspirating, make sure that I'm not getting blood back, unless I'm specifically doing like an ultrasound-guided hematoma block. But I want to know that I'm not going to be injecting into a vessel, and then I can go ahead and bathe the needle with some local anesthetic.
Yeah, that's great. I just wanted to add a couple of things. There's oftentimes a question that comes up with regards to, how sterile does this procedure really need to be? When we're doing subcutaneous injections, obviously that's not really a sterile procedure, it's a clean procedure. You're gonna wipe the skin with alcohol and things like that. Particular lacerations are not sterile, we know that. But with this, it's more of when you're starting to do this, you wanna make sure that you are doing it in the most responsible way possible, especially because sometimes in the ED, you can often come under a lot of criticism from other places that are doing these sorts of procedures more readily. And so you want to make sure that you're doing everything properly. So I would recommend that, especially when you're first starting out, do it essentially full sterile procedure with like a ultrasound probe cover sheath and some draping to the area with sterile towels at least, and sterile ultrasound gelling is key. The data doesn't necessarily support that, but it certainly will make your life easier when you're trying to get this through your committees or whoever you want to advocate for. The other thing is, when we mentioned block needles that we used earlier, one benefit of using those block needles is that it comes with an attachment, like an IV extension tubing attachment to the back of it. And so what we do oftentimes is a two-operator technique. And what I mean by that is that one person's holding just the needle at the hub, and the other person is holding the IV extension tubing with that local anesthetic and the syringe. So that gives you a lot more dexterity to be able to control the needle appropriately to the target, because that's really the key here. And when you're holding the back of a syringe, for example, it's a lot more difficult to actually direct the needle to exactly where you want to go. So for people who are starting out, I would also recommend trying to find a way to set up that technique. If you don't have the block needles, you can do it with a spinal needle, for example, as well. You just look up a short piece of maybe like 3 or 4 centimeter of IV tubing, and you can hand that to an assistant who will then inject the appropriate dose of anesthetic when you ask them to.
One other thing that I would mention is that whenever the trajectory that you want to go is actually underneath the nerve. Sometimes there will be some air bubbles that are inside the syringe that you have, and if you inject it superficially to the nerve, sometimes those air bubbles will actually impair your ability to see the liquid bathing around circumferentially around the nerve. So you want to initially start by going underneath the nerve. So oftentimes I'll have to adjust my trajectory based on that. Additionally, if you have a learner with you, like a resident, for example, what you can do is you can make a a little pocket of fluid around the nerve, again starting below the nerve. But once you have a little pocket of fluid there, you can withdraw the needle a few centimeters, hand the probe and needle off to your learner so that they have an easier target to get to, and you already have some local anesthetic working, and it allows the learner to sort of gain some experience in doing the ultrasound-guided regional block.
Perfect, guys. I really want to get into that because I feel that even a lot of my physician listeners, they have a hard time getting the nuances of that. Sometimes the YouTube video doesn't have it. Sometimes they can't watch the YouTube video while they're driving. So I appreciate you guys for going to that. One question that comes up often, and I notice this depending on the specialty that I'm working with, some people want, lidocaine without epi, only without epi. Some people want it with epi. Some people say it doesn't matter. Depending on the block that you're performing, do you have a preference to use with epi or without epi? And is one safer than the other? Because I hear, the dogma of using epi is bad, but when I actually look the stuff up in PubMed, I'm just absent of the data. So can you guys talk about whether you use epi or without epi, and have you ever had an issue as far as having an adverse event happen because you used epi in a certain area?
Sure, that's a fantastic question, Jimmy, and one that doesn't really have a clear answer, so I appreciate it. Knowing that we're kind of operating well outside the data here, the fear is that there's a theoretic risk of some neurotoxicity to kind of some of the smaller fibers because the epi can cause some vasoconstriction and you're directly injecting it very close to the nerve. So the thought is that it can maybe damage some of the nerve fibers. So with that perspective, some people say, for these regional guided anesthetic techniques, you don't necessarily need to use epinephrine because it's not like a subcutaneous injection where you want to get that vasoconstriction effect. The converse argument is that it may also help to identify early local anesthetic or intravascular injection when you're using epi, because patients will have some of those findings that are consistent with having epinephrine in their vasculature. So you may see increase in heart rate or things like that on the telemonitor, which would give you a tip-off that there was an inadvertent intravascular injection. So what do I do in my practice? Really, I don't know that there's a real benefit or a detriment to using epinephrine. I'll oftentimes just use whatever's convenient to me. So if that in our ED, we regularly stock lidocaine with and without epi, and then the remainder of the anesthetics that we have readily available are generally without. So the ropivacaine that we carry and the marcaine or bupivacaine that we carry are generally without epinephrine that's readily accessible. So that's usually what I use, just what's convenient to me. But honestly, I don't have a strong feeling one way or the other.
One theoretical benefit of epinephrine, and this is probably better for a landmark guided approach, is that if you accidentally inject intravascularly, that there can be some tachycardia that you see on the cardiac monitor. So it can let you know that you're potentially in a vast vascular territory that you're not trying to enter. And so that is a theoretical benefit. I've never seen it. I don't think that I've ever accidentally injected intravascularly, but it is a theoretical benefit. So
yeah, I don't know. A lot of our patients are beta blockers anyway, so I don't know that you can rely on it necessarily.
Perfect. Well, those are the key things. I'll talk about pharmacology at a different time. But for people who listen to this and say, "Oh, well, you're just a pharmacist, you don't know anything," they want to listen to Pharm So Hard podcast. What are some other resources that you guys use or that you would recommend for people who want to get more involved or understand ultrasound-guided nerve blocks a little better?
Some good online resources that I found. Some easily digestible ones for people with attention deficit, completely unlike myself for sure. The 5-Minute Sono podcast, which is done by Jacob Avila, has a bunch of quick, obviously 5-minute videos that really quickly go through indications, contraindications, relevant anatomy, and then videos of the block actually being done. Other resources that I found have been like the New York School of Regional Anesthesia, so NYSORA is another good one, and then the Highland Ultrasound Group has a bunch of really great articles and videos on the regional anesthesia ultrasound guidance.
Yeah, I think the key is you need to do your appropriate preparation before you go about doing these. So I think like things like podcasts and YouTube videos are great when you're trying to supplement your knowledge, or especially for like a just-in-time sort of thing where you're like, I read about this a while ago, or maybe I went to a workshop or a conference, but I just want to kind of remind myself of the indications, contraindications, anatomy, especially. And it's always nice to be able to refer to those things. Some of the more comprehensive things would be like the NISORA. They do a really nice job. There are some apps that are out there as well. But really, before doing this on a patient, just like anything else, you want to make sure you have the right basis. So whether that means, finding a colleague that is comfortable doing this sort of stuff at your shop or an adjacent shop, potentially going to a conference and doing a workshop, or even just reaching out to some other specialties, whether that be anesthesia or someone else like pain medicine in your institution, and kind of following them around, seeing how they do things, and adding that to your repertoire, because you really want to be able to be confident about this before you go about doing your stuff.
Perfect. And the last question I have for you guys before we close out, I know that there's sometimes some challenges when it comes to getting some of these agents, depending on your institution. What's some things that you would like for all pharmacists, no matter if you're at a small community shop or you're somewhere big and academic like we are here, what's some things, some tips, or some things you would like your pharmacists to know when it comes to these ultrasound-guided nerve blocks and the agents that we're using?
I think the biggest ones are to know which blocks are going to be best suited to use a long-acting agent, which ones are going to be best suited based on the risks and benefits of the procedure to do a short-acting versus a long-acting agent. So like Dr. Shah mentioned earlier, some of the brachial plexus blocks have a potential adverse effect of causing your diaphragmatic paralysis. So knowing that block is not going to be a good one to use bupivacaine or ropivacaine for, you're going to want something shorter acting like chloroprocaine or lidocaine, which is usually more readily available. So just knowing which of the agents is going to be appropriate for the block, and then of course for the patients as well. So knowing if they have a history of allergy to amide versus ester type, just knowing general pharmacology knowledge as well as your pharmacodynamics and pharmacokinetics regarding each of the individual agents, and that is going to be used for the patient that's in front of you.
Yeah, I think from my perspective, I often rely on the pharmacist to know kind of what we have available to us, where it's located, especially like things like intralipid. I recommend all the docs who are listening to this, like you got to know the doses and how to give it. But a lot of times that's going to come down to the pharmacist, and you're going to have a little bit more knowledge about that as well. So being able to kind of talk to your doctors or talk to your providers about, oh, do you want me to have this ready, or do you know where this is located, and how to give it, and the pumps and everything like that are associated with it is key, because it makes everyone feel a lot more comfortable. The other thing that the pharmacist can do that's super helpful is kind of advocate to get these things down in the emergency department. Having it upstairs or in a central pharmacy isn't really a lot of use, because a lot of times these patients come in acute pain, and you want to give them something relatively quickly, or do the procedure relatively quickly. There's going to be a big delay to getting the medication. That's going to drive me to say, hey, I want to get this person some pain relief sooner rather than later, and I may be pushed to give them some, IV opiate or something like that to try and do that, and that's going to take away from my ability to do a procedure. So if it's right there in front of me, I say, yeah, let's go ahead. I have 5-10 minutes right now. Let me go ahead and do this procedure and give this patient some relief. So having it in front of you is a really, really big benefit.
Right, I agree, and I think if I could impart one thing onto our ED pharmacists that are going to be listening, it's just know how to fix the problem that I created. So knowing where the intralipid is, exactly what the dose is, how to set it up, because I'm just going to be thinking about the procedure that I'm doing and how excited I am about it, and not the sort of oh no moment of, well, that looks like a wide complex tachydysrhythmia and my patient's now unresponsive and I was just about to repair their hand laceration. So if you could just know how to fix the problem that I create, that's a great starting point.
Perfect, guys. And I always say, from an ED standpoint, or just a pharmacist in general, our job is to take it brain to vein. And it's literally to take what's in the provider's head and make sure you can take it to the IV pump, through the patient's vein, and rescue the patient. So we're like the ED's lawyer. We're like we're just the Robin to you guys' Batman. And I think just having things there, knowing what to do and not panicking, creating a protocol so if you're not in the ED that day, there's another pharmacist filling in, they can easily assess that and making sure it's posted in different places. So that's really what it comes down to. And there's a lot more we can talk about, but I wanted to limit it for time and for this being a new variation of what we're doing, we're gonna stop it there. But for all of the studies, all the things that you can nerd out on, I'm gonna place in the show notes at pharmacistheart.com. Again, follow us on Twitter at pharmacist_hard, and we can reach out to us and get more there. Do you guys have your Twitter handles you want to mention?
Oh yeah, sure. I'm Olip, AALAP_MD on the Twitter.
And I'm Quintensivist, so QUINN Tensivist.
Well, thanks so much for having us, Jimmy. We really appreciate what you do for us downstairs. And yeah, you definitely take a brain to vein. You always seem to have everything that I'm about to ask for already ready at the bedside. So big shoes to fill for everyone out there.
Yeah, this is a lot of fun, Jimmy. Thanks.
Yeah, perfect. Well, I'm hoping to do a lot more of this. Again, the Pharmaceutical Heart Podcast is an emergency medicine and hospital pharmacy podcast. So we want to make sure we introduce all providers in the ED and give them an avenue to talk to pharmacists. And I want to bring other providers to the Pharmaceutical Heart Podcast. So definitely check us out on there. And you guys are ended the same way every time. You don't have to work in the ED. You don't have to be a pharmacist. You don't have to be a physician. But everything you do, make sure you farm so hard.